creating our room. All right. And hello, welcome to another episode of the Residency Match Insiders. And today's topic is on code status determination. And it is a very important topic for people that are going to start doing rotations because it does help us a lot to get to know more the patient. And I will tell you more and more on how this is important and how this will help your inpatient rotation. And with us, we have a student. Could you please introduce yourself?
I'm Keertana, so I'm from India, and so I'm going to apply for match this year, and as of now, I don't have any inpatient experience like in the US as such, but I do have inpatient experience in India.
Okay, all right. And this is great for you because I'm thinking that you will get to start doing your observerships and externship rotations, and this kind of information will help you shine on your rotations, because usually we don't expect observers from different countries or even medical students on third year or fourth year rotations to know about this, because this is a very advanced topic. So if the time comes that you have to present me a case and you tell me, Dr. Munoz, the code status for this patient is DNR, and I talked to the family about this and they confirm that this patient is DNR, you will create a great impression because you found something that is very important for the treatment plan for this patient. And I will tell you why in a minute. Now, tell me a couple of things, Kitana. In India, do you ask your patients about the code status? Do you know what the code status, what does that mean?
Yeah, it's like, are they willing to be resuscitated in case of any emergency, or they are not willing to be resuscitated?
Yes. Okay, so that's the bottom line. It's kind of the bottom line, right? So it is the same here, but someone has to ask, and usually the nurses don't ask. Usually, no one else asks except the person that admits the patient into the hospital. Why? Because it takes some time to get this answer. It takes at least a good 10 minutes conversation with the patient or the family to explain what this part is, what this question is. And people get scared. So we will get it done, but I'm going to tell you why this is important in rotation. Not only because you will save me a lot of time if you find something that could change the treatment of this patient, but it's also important because for me to be able to put orders in the computer system, I need to know if this patient is full code or DNR.
Mm-hmm.
The computer system will not allow me to move forward if I don't have this information.
Okay.
Okay? So you have two options when coming to this question. You have two options. One is full code, and it means you want to be treated with everything available in case your heart stops or you go into cardiac arrest. You want to be resuscitated, maybe get an electric shock, and even be intubated. That is full code.
Okay.
You also accept to use vasopressors, even if that means to get a central line on you that could be a little traumatic. It could cause pain, it could cause bleeding. So you agree to all that. That's full code. And the other option to this is DNR, do not resuscitate. So meaning that in case, like, my heart suddenly out of the blue stops working, I don't want to be resuscitated. I don't want you to do CPR, to do any medications, nothing. Don't touch me, let me go. And DNI means do not intubate. Now, a patient can be emergently intubated. Could be, let's say a patient comes in complete coma and with a cardiac arrest, and he is already in the way to the hospital. He was resuscitated, and he is now intubated. He's now intubated, but now you talk to the family, you explain how difficult is his condition and how poor is going to be his recovery. And you say, and the family says, okay, from now on, even if he's intubated now, you don't want this patient to be resuscitated again if that happens again. If his heart goes into cardiac arrest again, you don't want him to be resuscitated anymore. So see, even if the patient is already intubated, the family can make the determination to not resuscitate or intubate anymore.
Okay.
Okay, and the next set of orders, the next part of this determination of code status, it's what's called the comfort care orders, comfort care status, which means, let's say you have a patient that is very, very sick, it's comatose, it's on septic shock, and the blood pressure is super low, systolic is low in the 60s, and he is already on a vasopressor or 2 vasopressors, and he's not, his blood pressure is not improving. You talk to the family, and the family says, you know what, Dr. Munoz, I actually want my mom to be on comfort care. I want you to not to do anymore. I want you to stop all that you're doing, and I want you to let her go.
Mm-hmm.
So that is comfort care. Now you stop everything you're doing and you focus on managing any other symptoms that come with the process of dying, like it could be shortness of breath, it could be agitation, it could be pain. So you manage those symptoms to allow the patient to pass peacefully. Okay? All right. So this is all what these orders mean. And now I want to tell you something. When you are doing these rotations and you have to talk to the family, you have to talk to the power of attorney. In California or in all United States, there's 2 forms that you have to be aware of. Because sometimes you happen to ask the family, hey, by the way, do you know if your mom would like to be resuscitated, or that she doesn't like to be resuscitated? Or you ask the same to the patient, and they tell you, oh yes, I have a living will, I have an advance directive. So that doesn't mean that you necessarily have the advance directive with you at hand. It means that the family, the patient has one, but that doesn't necessarily mean an answer to your question. So if the family says something like, we have an advance directive from my dad, unless you can see the advance directive where it says, I don't want to be resuscitated, I don't want to be intubated, or I do want to be intubated, I want to be resuscitated. Unless you can see that form, you still have to ask the patient and find from their mouth if they want to be resuscitated or not. See, in the hospital setting, it's important that you find out that from the patient or from the family. Even if there is an advance directive, you have to find that out. And this is the important part, and this is the part that's gonna shine stars on your rotation, is that you get the answer, and immediately you go to the nurse station, get what is called the POLST form. And the POLST form, it spells POLST. The POLST form, I uploaded a link to the conversation. The POLST form, it's a document that has the orders that the patient has agreed to. Like, let's say you're talking to the patient now about let's be full code, and then you check the box that says full code, or you check the box that is DNR. You check that out, and the patient signs. You make the patient sign or the family sign, and that POLST form goes into the patient's chart. And that is the final word. It is very important. If you present that to your attendings, they will be very surprised that you know what is a POLST form and you know how to fill it up. Do you have? Could you open a pulse form from the link in the on the video room?
1 second. So, where can I access that link?
It is on the group on where you found this chat room. In the comments, I posted the link to the pulse forum. Did you find it?
Sorry, I couldn't find it.
Okay, don't worry. I will go through it so you can have an idea of how this is. Okay.
Okay.
All right. So the pulse form has three parts: the A, B, and C part. So the A part says cardiopulmonary resuscitation. So if a patient is full code, it will be attempt resuscitation is the first box, which means selecting CPR requires selecting full treatment in section B. So you go to section B, and if the patient is full code, on section A is attempt resuscitation, and section B will be full treatment. And section C,
Okay.
you will also have to check on one of the three boxes. And then section D is just the you signing your name, signing for it, adding your license. Of course, if you're doing an observership only, you have to have your attending sign this part, not you.
Okay.
And then if the patient is DNR, and this is the tricky part with the pulse form, if the patient is DNR, it's going to be on section A, will be the second box, do not attempt resuscitation, DNR, but that's just DNR, do not resuscitate. So on the section B, it won't be full treatment, it will be either the second box or the third box. If the patient wants, let's say they still want antibiotics, they still want vasopressor support, they still want, I don't know, a trial of chemotherapy, it still is selective treatment, so you check on selective treatment. And or if the patient doesn't want any of that, he just wants to not to be resuscitated, and now he wants you to let him pass peacefully and focus on comfort management only without using antibiotics or without using vasopressor support, then it's comfort focused treatment, which is the third box.
Okay.
For that patient who is DNR, also the artificial nutrition that you will choose will be none, if the family doesn't want to do any artificial nutrition. But if the family said, no, let's try an NG tube for nutrition, or maybe let's get a G tube, then you can choose either the first box, which is long-term artificial nutrition, or a trial period of nutrition. And then sign the paper, that's it, okay? So just be aware that this thing exists, and in your rotation, you may have to do it, and this could be a lot of help for your attendance. Okay?
Yeah. Okay.
All right. And okay, so I just want to do a little conversation scenario on this, so I can let you know how I discuss this topic with my patients, because it's not easy, and sometimes if you don't ask the right way, patients, families get a little scared, everyone gets scared, patient is dying, oh no, my dad is dying now, what are you saying? So the way I start the conversation is, after I ask all my HMP part, I go and ask, hey, so by the way, I have one more question for you, and this is a question that we have to ask to every patient that comes to the hospital. It's not just for your dad, it's for every patient, and it is about the goals of care. So yes, I always start saying, do you have an advanced directive? And they say, sometimes they say, no, I don't have one. Or they say, what is an advanced directive? And I tell them, well, an advanced directive is a paper that many patients have signed in advance already, to indicate if they would like to be resuscitated, if they would like to not to be resuscitated, if they would like to appoint someone to be the person making decisions for them in case they can no longer make decisions. That is an advance directive. And they say, no, we don't have one. So, okay, so your dad now is not able to make decisions for himself because he's very sick, he's comatose, and his condition is very critical. So I want to ask you, as his next of kin or the power of attorney, I want to ask you, in case your dad suddenly dies, let's say his heart stops working and his lungs stop working right now, and he need to be, he is identified that he's having these problems in the hospital, we can do many things for them. We can keep a patient alive, and that means that we can resuscitate their hearts if that's what the patient would have wanted. Or if that's not something you want, we could stop here and let him go.
Okay.
So the family usually they ask you, so is my dad very sick? Is my dad do you think he's gonna die? And so this is the time that you ask them, you tell them, you know, it's his condition is very poor. If that's the case, you tell them his condition is very poor. He's on septic shock. His blood pressure is dropping despite being on vasopressor support. Usually patients in this condition, they don't do well, their prognosis is poor. So I don't know, you can explain that, but usually I just tell them this is a question that is a protocol question for everyone. Everyone that comes to a hospital needs to have a code status determined by the doctors. So if you want him to be resuscitated and be kept alive by any means, then we can do that. But if he has told you before that he wouldn't want to be on mechanical ventilation or to go through CPR, then we don't do it. But that's just a hypothetical case, and we need this answer from you because we need to be aware of what are we going to do if something goes wrong and he really needs this type of therapy. And the families usually they will say, do I need to give you this answer now, or do you need can I come to you for this answer tomorrow? And the problem with this is that it has to be answered at that point. You cannot wait another day for them to talk about it because the hospital needs this answer. So you can explain, sir, I really need this answer today, right now, because we don't want to do something that the patient or the family wouldn't want. So to the best of your knowledge, do you think that your dad would want it to be resuscitated? And if they say yes, or let's do it, or let's keep on going, let's keep the fight, then you check for full code. But if they say, no, I don't think that he will want it to be resuscitated, I think that we shouldn't resuscitate him. So then you start filling up your pulse form for the DNR part and ask him more questions about, okay, so now would you like treatment, selective treatment or treatment for comfort care? And then you keep going through the pulse form. So it is a very difficult conversation. Basically, I always start telling them, you know, this is just a protocol question in the hospital. I have to ask you, it doesn't mean you are dying, but it makes me aware of what your goals are. In case something happens, because we never know what's going to happen in the hospital, I need to be aware. And so in case something happens to your heart, would you like to be resuscitated? Or in case that happens, would you like just let me, would you like just want me to let you go? And to be honest, patients that are very elderly, very sick already, they already thought about this, and they will tell you, you know, you can keep treating me, you can keep treating my CHF, but if my heart stops, let me go. They will tell you that. And you know why this is important, Kitana? It is because, why is this important for us, for the attending doctors? It's because if, if you are admitting a very sick patient from the ER,
Mm-hmm.
and you're presenting me this case, and the plan is so big and so complicated, like, oh, we have to do a central line, we have to do this treatment with pressors, we have to do these antibiotics, call the infectious disease, call pulmonary, call all these people,
Mm-hmm.
and take this patient to the ICU, and all this complicated patient treatment, and he is full code, it's fine, let's do it. But if you tell me that this patient is DNR, DNI, or you even tell me this patient, the family wants comfort care dog, they don't want any of this. If you tell me all that, I will be like, oh wow. So then this information that you just gave me, it will be it will preclude me from doing all that amount of work and just focusing on something simple like respecting the patient's wishes. Okay, Keith, and now if the patient is not gonna do any of this, we know he's gonna die because he's very sick. So we're gonna focus on the comfort of the patient. He's not gonna go to ICU anymore. He's gonna go to a regular floor where we will focus only on symptom management. And at this point, if the patient is actually passing, then we order something like a morphine drip or a dilaudid drip or an Ativan drip, just to comfort the patient, not to allow him to go on agitation or pain, and letting them pass. See?
Yeah.
So
Okay. Mm-hmm.
if you give me that information, you could make the hospital stay very easy in terms of management, and very rewarding for us to treat a patient that doesn't want all these heavy treatment. They just want them to be in peace. Um, and also, why is this important? Because you, as the intern, as the observer, as the patient that I have, give you the responsibility to do the HMP for this person. If you tell me that, it means that you really talk to a patient or to the family in detail. It means that you know the way to make an HMP. So yeah, go through this video again and familiarize yourself with the pulse form. I think it will be very important for you during your rotations. You will, believe me, not many students can get to the bottom of the pulse form and fill it up. So if you do that and you know how to do a code status determination conversation, you
Mm-hmm.
will be excellent on your rotation.
Yeah. Thank you. Thank you so much.
Do you have any questions about this?
Um, so this about the status, the one is do not resuscitate, and another one is do not intubate, and another one is to resuscitate, right? Um,
Yes, full code is resuscitate and
full
intubate.
code. Okay.
Um,
Okay.
and the other one is DNR, DNI. They actually come together.
Mm-hmm.
So DNR means do not resuscitate or do not intubate. They usually come
Okay.
together. But remember, you can have the scenario that the patient was already intubated by the time that you come to see them.
Yeah. Mm-hmm. Yeah,
And,
understand.
and
Okay.
then now you talk to the family and say, hey, you know, your brother is super sick. He had a hemorrhagic stroke, which is large, and he's very likely to be brain dead now. If in case his heart stops again, do you want him to be resuscitated again? Because when you're intubated, your heart can continue to go into cardiac arrest, right? So
Yeah.
if they
Okay.
want to continue resuscitation, then you keep going. But if they don't want, even if he's intubated, that's the end. And you will see that many times in the inpatient care setting, because as in the inpatient setting, we treat the sickest patients. We treat the ones that are actually dying. It's very important for you to find out this. Now, if you present this case to your attending, and your attending says, oh, okay, so he is comfort care only, he's DNR only, and he's very sick, should we
Mm-hmm.
call the palliative care consult?
Okay. Mm-hmm.
Yes, ideally you should call a palliative care consult, because maybe this patient is going to be placed into inpatient hospice. or
Okay.
or this is a patient that we can send home with a hospice team to take care of him at home to allow him to pass at home. So in your presentation, in your assessment and plan, once you present this problem number one, septic shock with multi-organ failure, the family has requested for the patient to be comfort care only. They would like to take the patient home. I'm gonna call a palliative care consultation to determine goals of care and hopefully transfer this patient home on home hospice.
Yeah. Got it.
Do you know what's hospice?
Yeah, it is for terminally ill, like those who have less than 6 months of life expectancy.
Yes, yes. So hospice is a program where we focus on comfort care only, usually at home for the ones that have that time to go home and have the end of life transition at home. But
Mhm.
it can be inpatient hospice, where a patient was determined to be very critical inside the hospital, and you anticipate that this patient is not going to make it home. He's probably going to die in 2 or 3 days. So you call this consult to be done inside the hospital. It's called the inpatient hospice, or otherwise called GIP.
Okay. Okay.
Okay.
Mm-hmm.
So thank you very much. I hope this video, this conversation was useful for you.
Yeah,
Go
it
through
was.
it again. Go through it. Go back to the everything that we have discussed here. Go back through that. Try to read about it.
Mm-hmm.
So when the time comes that you have this rotation, you understand more and more about this. Um, Familiarize yourself with the pulse code, pulse form, and I
Okay.
think you should have a good rotation if you go through this. Also, if you don't have much experience with the American healthcare system and rotations on inpatient care setting, go through the previous videos that I have on this Facebook group, because there's one that we just did on how to make an HMP,
Okay.
and I will check that out. And next week, I'm planning to do something about how to find research or observerships opportunities in the United States.
Okay.
Um, and if you have any suggestions on any topics that you would like to discuss or to talk about, just send an email and we will do that.
Yeah, sure. This class was really helpful. It was very, very
Okay.
helpful.
Well, thank you very much, Kirana. Thank you for your time. What time is in India now?
Um, it's 10 a.m. in the morning.
Oh, good, good. It is 9:30 here, and I wanted
Yeah.
to change. The previous class was in the middle of the day, so a lot of people were sleeping. But
Mm-hmm.
hopefully, one week I will do it in the morning. One week I will do it in the evening, and yeah, hopefully everyone
Yeah.
can get to see an episode and participate in it. But thank you very much. I leave you now, and good luck to you. If you have any questions, please send me an email. The group is growing, so as for now,
Sure.
I have a lot of time to talk
Mm-hmm.
about this. I'm a hospitalist.
Mm-hmm.
Um, a hospitalist can be a family practice doctor, or can be an internal medicine doctor, and we work 7 days in a row, and then we stop working for 7 days, and then
Mm-hmm.
we go back to work for 7 days. So I can say that I have good amount of time to give to these classes. So we'll probably see each other next week in the next
Yeah,
topic.
sure. Next topic is really good. I really need to attend that. It's
Okay,
about
see
the
you later
research and
then.
observation. Yeah.
Yeah, no, I'm thinking I'm gonna do that one for next week for sure.
Yeah, that will be really helpful because we are literally struggling that.
Yeah, it is hard, because now in the past, students could arrange for the rotations with with hospitals directly, but now hospitals have restrictions for COVID, and
Yeah.
also there were opportunities to do it in clinics. But when you research for clinics that you want to talk to the doctors and ask for this, if the clinic it's a government affiliated clinic, they have the same restrictions. But if it's a private clinic, where like me myself have my own clinic, the Dr. Munoz clinic, then it's my clinic, then I make the rules there. But it's different if it's the government is running a clinic and you work there, then you have the same limitations as the hospital. Yeah. So we'll see. I will prepare some good information for that, and hopefully we can discuss more in next week. Okay?
Yeah, thank you so much. It was nice to meet you virtually.
Yeah, nice to meet you. Have a good day.
Thank, thank you
Bye.
so much. Bye.